Hello, everyone. This is Mark Plaster, Senior Executive Editor of Emergency Physicians Monthly, and you're listening to EP Talk, the place where emergency physicians, aka ER docs, come to talk about things that are relevant to our lives, our personal as well as professional lives. And my guest today is Jonathon Feit from Beyond Lucid. And he has an incredibly innovative program. I'm going to let him tell you about it because I think all I can really say is I want to introduce it by saying this is one of the most innovative programs that cares for the caregivers, and especially when it pertains to COVID-19. That's the reason why I pressed John to get this on the air as quickly as we could, because I think this is very timely. So, John, take off. Tell me a little bit about Beyond Lucid to start with, and then we'll go and get into the program.
Well, I appreciate that, and thank you for the very kind words. We're pretty excited about the impact that this approach to managing internal exposures for mobile medical providers, fire and EMS, to a degree that needs to be added to that list. Police, basically first responders, folks who are going out into the field and taking care of patients who are running the risk of being exposed to the coronavirus. And thankfully, we've had a measurable impact that I'll be happy to tell you about today. So basically, our company, Beyond Lucid Technologies, 11-year-old startup. We're one of the rare healthcare IT companies that is both small and demonstrates that it's possible to do well by doing good. We've got a sustainable underpinning, which is very nice. And we started our business, by providing an electronic patient care record, basically an EHR for ambulances, for lack of a sort of more colloquial description. But over the years, realized that the capture of data is to some degree a commodity. If you wanted a government cheese version, you could get one. If all you're doing was checking some boxes, meeting some compliance rules. For us, it was really much more important what you do with data. So to be able to, for example, when you talk about emergency physicians, one of the most important messages that I ever heard is actually from an interventional cardiologist turned investor in the Philadelphia area a number of years ago, had essentially described his job as an emergency doctor as working in the absence of information, right? He basically says, we don't get the EMS data in a timely or complete fashion. We don't know what to trust, so we have to figure out what to do. Yeah. And we saw our mandate as saying, well, what if you don't have to work that way, right? What if you could have this compendium of knowledge? That's really the way we look at our job, is to capture the knowledge that is contained within the body and practice of the pre-hospital, out-of-hospital, post-hospital care providers who work in these trucks often with light bars and sirens, but they're the first on scene. And so the movement of that,
you're talking to an old guy who started back when ambulances used to call in on every single run and give you. And give, well, most of the ones that come to our place don't. And then they came back with these long written records that all came back in 30, 40, 50 minutes after we had actually worked the patient up, and were really of no value whatsoever. So, talking about a timely EHR coming from the field, incredibly important.
Well, so that's actually, what you just described is actually the status quo that we as a company battle against, and I can probably give you some horror stories you've already heard about places where, for example, 12 lead EKGs are being faxed to the hospital or being sent digitally, but end up at a printer, and that printer may or may not have any paper in it. These are real things. Like, I'm a technologist, I'm not a clinician. So to me, it was mind-boggling, the idea that we're talking about this in 2020, 2019. This is crazy. So, those are what we did, and so close those data gaps. But one of the most important adjuncts to the practice of mobile medicine is the mandate that comes to avoid readmission avoidance, or readmission avoidance mandate. So try to keep people out who don't necessarily need to be there. We're talking about now about flattening the curve, but really about making sure that beds at hospitals are being reserved for the folks who really need it, right? Not folks who can better take care of elsewhere. That has fallen in the EMS and fire space. It's fallen under an umbrella known as community paramedicine, also known as mobile integrated health, which basically encompasses largely chronic care. And over the last couple of years, we have identified, and it was pointed out to us, that there's a very thin line between chronic care, congestive heart failures, COPD, diabetes, et cetera, and addiction. So substance use disorder, folks who are coming in and out of the emergency department for acute care encounters, right? Again, people that are often going to be seen over and over again. And so by and by, in the middle of March this past year, one of our agencies, Cypress Creek EMS in Spring, Texas, northern part of Houston. Yeah, so they came up with this wonderful idea. They actually reached out to us. It was, I'll never forget it. It was the 13th of March. And they sent us a note basically saying they're using our software for community paramedicine in this readmission avoidance program. And they'd like to find a way to incorporate their crew. And basically said, I don't know what you're talking about. Like, this is not a scheduling program, right? So it's not for your staff. To which they said quite directly, you misunderstand. We have had personnel who are on our staff who are going out to take care of these COVID-19 suspected exposures or confirmed exposures, and they are themselves becoming exposed. So we would like to place them into a short-term 7, 14, 21-day type monitoring program like you might otherwise do for a chronic care patient, and essentially treat them like a chronic care patient. And go, know who they are when we go out and check on them, what they've been through. I say very often, I'm sure I'll say it a couple times today, looking at those types of programs, they're not clinical in nature, they're data related, right? I don't tell you as a clinician how to do your work. I try to empower you with as much information as I can before you get there, so you have some idea what you're going into. Right. And so this ethos and approach of going out and basically taking care of those who are putting themselves out on the line, being able to monitor them. When I looked at what our industry was doing, there were so many people talking about the need to care for the patients, and that's important. But my view was, who's going to care for the people who are caring for the patients?
That's right. Everybody is talking about jumping in on you here. Everybody's talking about the front line, caring for the people in the front line, but nobody's actually doing it. Everybody's thankful, but at the same time that we need to care for the people on the front line. So that's what you're talking about.
That's exactly right. Now, I don't know if you were aware, but this is coming in the perfect week. This is EMS Week 2020 is upon us right now. You're in the midst of it. So it's kind of the perfect time to be talking about this. One of the things that I've always tried to do, and it's a bit unusual because, again, I'm not a clinician. Our company is the only technology company in our industry, at least within our sphere of data and documentation interoperability, that was founded by 2 non-clinician MBAs. So we're data geeks, we're economics geeks, like we're all about that. But I can't tell you how to stick a tube down somebody's throat, and even if I could, I'm not qualified to do so in any official capacity. So to us, it was very much, if we see these openings, right? And this has really been the hallmark of our company over years, is to see things where people don't, because our eyes are truly different. And at the same time, when you're looking at the patterns of infection associated with coronavirus, they have been happening in places en masse, right? So a lot of the center of the country is for example, one hospital, I won't mention it, but it's a fairly large hospital in the Midwest. And they actually took over an adjacent parking lot and turned it into a field hospital, like we've been talking about in the news over the last few days, to deal with overflow. And then kind of like the girl who's all dressed up for the dance and doesn't find anybody to party with. There's nobody there. Whereas what we've been finding is in places like Los Angeles, in fact, about a week and a half ago, when the numbers started to plateau, the LA County Fire, which we've been working on, which again, very, very proud because it can take this type of technology and apply it at scale, right? I mean, there's not a lot of places bigger than Los Angeles County, but their numbers had flattened. And so they were starting to get ready to go back to business as usual. And then on a Sunday evening, they got a report of an individual who, on their staff, who had been exposed, who had tested positive, who had not been aware that he was positive and asymptomatic, and came to work. And now there's 48 exposures. And by 2 days later, there were 97 exposures. And so the exponential growth associated with, I don't think that's quite exponential, but anyway, you know what I mean? The large growth of this network effect of infection really requires you to keep in mind that some places are going to get hit very quickly just by simple congestion. So we were very, very proud to have a software system that we could deploy quickly. We actually deployed in Los Angeles County within 5 days, one of our fastest deployments. And to do that at a scale like Los Angeles County is just very exciting to us, because if you can do that, you can, the small guys become, I don't want to say piece of cake, but it's a whole lot easier to know that you can.
You started at the top. In other words,
but again, credit where it's due. This idea of managing the internal personnel exposures. Well, I think what's happened in New York is tragic, and for two reasons. One is obviously the loss of life and exposure and pain and concern and fear and everything that people have been hearing coming out of the New York area and New Jersey and Connecticut, that whole region. But the other is because this thing happened so quickly that even though, for example, the same tool, this is a true story, the same tool that we deployed in Los Angeles County could be very well deployed in New York and its region. But the problem is the noise is already too loud there, right? You can't bring in innovation in the middle of the crisis, right? So that's one reason why now we're in a kind of a crucial eye of the storm period. If we're looking towards the fall and a second wave or a possible third wave, whatever comes after that, but now is the time to get in front of people and explain that there have been some positive results in the first wave where people kind of got caught by surprise, and now there's a second wave, and here's some tools that people need. And so the big question that our industry is going to have to ask, which I think you hit on the head, is who's really doing it, right? Is now we have the vista. We have the ability to see that real pain can come out of this. Death is its own tragedy, but the pain of people who survive is a very tangible reality, right? And when you're someplace like New York or Chicago or Houston or Los Angeles, force readiness is crucial. When you're in rural environments, it's almost worse because you don't have backup providers, right? So you don't have the ability to call in a neighboring service. That neighboring service is taking care of that town. They don't have the ability to come in and close ranks.
Suddenly your staff is cut by 10%, and then everybody's trying to double and triple triple shifts in order to cover. I mean,
that's very real.
Emergency medicine has found that if you get a person who leaves, or you get understaffed by one or two people, and suddenly everybody else starts getting slammed, and they start looking for the doors as well, because now they're overworked, and if they don't get released sometime soon, they themselves are either going to succumb to illness or depression or whatever. In an EMS situation, it can be a tsunami. If it sweeps through through the staff, before long, you've got nobody out there, or maybe the people that you have left are working so hard to cover for the people who are out that it becomes a positive feedback loop, and it can become a real disaster.
Yeah, they grind themselves down. I mean, this is that you hit all of this on its head. And that's why I think, now is kind of a crucial question of, can we best through the noise? Because, the number that I got from the union in New York was 25% estimate of EMS professionals out of work. Wow. And I believe CNN reported something on the order of 15% or so of NYPD called in sick. I mean, and again, one of the things that is so challenging in mobile medicine is its inherently fractured nature between, you've got fire, you've got EMS, and you've got police. And police, so literally the red, the white, and the blue is kind of the way we look at it. The red being the fire, the white being the EMS, and blue being the police. And they have different health organizations overseeing them or not. Right. They have internal systems that don't talk. The idea that police is not my daily bailiwick. But in this battle against this virus, they've been truly exceptional, as they are a front line in so many cases. And again, when you look at places like New York, the number of cops that they have on the street is so high that by sheer number,
35,000. The number is 35,000. They have 35,000 cops in New York City. It's the size of a good-sized town. Well, you had me at Lucid, so now tell me about how this program actually works.
So what it is it's actually made to be deceptively simple. As I mentioned, we sort of harnessed the chronic care monitoring components of our system, so longitudinal charting. One of the things that makes our company special, we're the only ones in our industry who actually do the following. We took an electronic patient care record, an incident-specific documentation system designed for emergencies, and we bolted on top of it a longitudinal charting system. So the kind of case management, chronic care management system for scheduled encounters, social determinants of health, for example, those types of sort of non-clinical longitudinal pieces of information that you need to capture about a patient. And we built it on top of the 911 service to allow for homogenization of the data. So there was actually a very specific technical reason we did that. We wanted you to be able to look at.
You're geeking out on me here, okay? And you're going to have to explain in non-geek terms what that actually looks like.
Sure. So let's assume you've got a patient who is a congestive heart failure or a COPD patient, right?
Okay.
Let's assume that that person is in a managed care program. Again, they're well taken care of at home as long as their oxygen is good. They know what meds to take. Someone's checking in on them, making sure they're fine. And earlier the day, you're going to go and check on them. I'm going to do a house call or a telemedical visit or whatever it is. And someone comes to that person's door, delivering a package, some walker by, whatever it is. And they stand up too fast and they have a hypoxic episode. So they keel over, they hit their head on the edge of the table, and now they're laying face up on the floor with blood gushing out of their head, and they got a head trauma, right?
Okay.
Plus it's an elderly patient who's otherwise ill, and so on and so forth. So we realized that the tagline for this is sometimes a wellness check isn't a wellness check. And I've done a good number of presentations and publications over the fact that any which, by the way, links to things I'm happy to share with you or your readers if they're interested in this. But the statistics are compelling on the number of times, you have a community paramedicine team, for example, go out to check on a patient that should otherwise be just a wellness check. Hey, how you doing? Make sure you're not lonely. Do you have the right food? And it turns out that person hurt themselves. And so you need to be able to look at the two types of data side by side. You need to be able to understand, of the 10 visits you did to this person in the last X amount of time, how many of them were good? How many were not good? Right? And to be able to understand, in light of that, how does that affect their care plan and their case history and all of that stuff? And so our architecture was based on this idea that if you can string together encounters with an individual over time, you get a picture of who they are. But sometimes those encounters are emergent, right? Just by their nature. Sure. And so that's exactly what we recognized in the coronavirus exposure context with these providers. You might monitor somebody over 14 days because they went on a call where a patient coughed on them. Or you needed to apply, you were doing CPR, and so you were aerosolizing droplets just by nature of the procedure. And so, if your PPE failed, if you didn't have the right PPE, or for whatever reason, you got potentially exposed. So I'm going to monitor you, and I'm going to check on you for 10 days. And maybe those 10 days are good. And on the 11th day, you spike a fever, or the 11th day, you start to have wheezing, or gastrointestinal issues, etc. You need to be able to indicate in the same longitudinal chart, something's changed. And this is no longer just a wellness check, you submitting a form about yourself. So we put the two things together so that you didn't end up with orphan data, and you could end up getting a more solid statistical picture, actionable picture on what's actually happening in your service. Now, remember, if you are a small service of, say, 35 personnel in a volunteer agency in the middle of nowhere, that is something you might be able to manage just fine with a spreadsheet. Los Angeles has 6,000 people. But there's no way to do that with spreadsheets. Look at New York's even bigger, Chicago, Houston, et cetera. You don't need to hit a large number of people to have a tipping point when you have a full-time operation as well. So infection control tends to be where this topic lives in mobile medicine. But there's also, but infection control is meant to be like you stuck your finger with a needle, and I check on you once, and maybe I check on you a month later, and you go get a prophylactic check and make sure you don't have some virus. It's not something that's well managed when you're checking on somebody every day for 21 days. There's a lot of data to be captured there. Yep. So what we did, again, we took this longitudinal tracking program and we threw a face on it. And that face actually came from the Los Angeles County Fire Department. They had devised a form that is something you could do on your phone, take about 30 seconds. It's check, 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 check on the World Health Organization and CDC guidelines as terms of the meds that you might have been taking for fever reduction, symptoms as they evolved. So we actually had to revise this a couple times, and they added things like loss of smell and so on and so forth that added onto the list. Fever came down as an indicator, and we essentially gave this to the providers as a very fast way of documenting themselves. And then behind the scenes, we took the results of that survey, which is basically what this was, and we bound it to the data model associated with the record system. So when you indicated a medication that you took, for example, it entered on the front end, it had Tylenol or Advil or whatever it was, and on the back side, it had the code. And so that code tied into a record for this person, tied to a date and an encounter and a triage level. And so if it turns out that you were not taking any medication, you didn't have any symptoms, everything was good, then it went and identified as a self-monitoring form, for example. But let's say on day 10, you indicated that you were having some shortness of breath or gastrointestinal issues, it would flag that record and it would bump the triage level up. So now you've got an identifier on there that someone in the health programs office in Los Angeles, or whatever they call it someplace else, infection control or nursing team, whatever it is, could see that on this list of hundreds or thousands of forms, these ones are starting to show.
It's like a red, yellow, green dashboard that for readiness that you would be able to see. Look at your entire staff and say whether they're at 80% readiness or 70% readiness because of the flags that you've attached to them.
It is, but what we did, which went a step beyond that, is red, yellow, green, black tend to sort of live in and of themselves, right? What we did was, again, underlying all of this, we created these records. And by doing that, it ties in other pieces that are part of the workflow in mobile medicine. So your schedule, for example, who's on what shift and where are they on a given day? Because let's say, again, you show, you go yellow on the list, right, to use your example. I need to now make sure that everybody that you've been in contact with, that's your contact tracing bit. So everybody who's at your firehouse or your EMS station, they're getting checked too. They might not be at the same level, but they're heightened, right? And gotcha. Tying that in with so now one of the big tasks coming on the hospital side is to be able to feed back the COVID serum tests or PCR test results, et cetera, to be able to say, okay, of these patients that you brought in, which ones turned out to be positive? And I can tell you that one of the largest hospitals in the country, and I guarantee you know, I can use names if you want, but they're a very large brand. You would absolutely know who they are, and they're in the Midwest. And I found out from their EMS team that they actually have a team today calling every crew that handled a patient that was found to have been COVID-19 positive so that they could feed that back. Wow. By phone. I mean, these guys bring in thousands, tens of thousands of patients a year. So what's the number that you're going to need? And I mean, FTE cost and time and latency. Wow. It's just a human process. So by layering onto this existing tech, we had, for example, the ability already for hospitals to feed back data. So we added onto that a COVID button. And so they can now say, well, this patient, select the line, identify them as COVID, that was the outcome, send it back to the chart. And so we utilize the underlying architecture of this longitudinal charting program for a specific use case that really became a microcosm for what would otherwise be months of monitoring of chronic care patients, or, again, patients that might be chronic but sometimes fall down and have an acute episode. And by putting that into this COVID context, you're able to capture the noise, which is everybody who's checking in and they're fine and it's all green, it's all green and all green, and then somebody goes up to red. And instead of having to scramble, you've been watching this. It becomes kind of a background thing that pings when something happens. And that has allowed folks like Los Angeles County, in their own words, to identify hotspots of infection before they even went through public health, because they were starting to see who needed to be traced based on our own system, rather than waiting until public health digested it and sort of sent out a bulletin. So that's really what we did. We kind of, it's sort of separate but equal. But the idea is that it's something that the responders, as you talk about, the responders can take care of themselves, and then use the data to correlate with the public health syndromic surveillance data that they're going to get on a broader scale, but not necessarily as frequently.
Let's talk about the. You've told me how the program works. Tell me exactly how a an EMS system, which I think would be the people who they're most interested in getting this system. Um, what's the requirements? What do they have to have? If they called you up, I said I'm the EMS director for Acme County and in Maryland. I'm in Maryland,
Yeah.
and I'd like to employ your system. Walk me through what would be what are the requirements?
Actually, very, very little. So the fastest deployment we did was 24 hours. We literally got a call on a Friday that there had been an exposure. It's an agency in Connecticut. There had been a suspected exposure, and they needed a deployment. Yesterday was actually the words that they used. And so that day, there's a little bit of paperwork because you're capturing some HIPAA data.
Mm-hmm.
So we need to get that signed up, but that's just a little bit of paperwork. They sent us a roster, or we could get that in some cases from a state. They can actually provide the official roster,
Sure.
and that's pretty much it. Then we get them the forms, and then everything else is set up on the back end. So the idea is that we get them a login, we get them the form that they can distribute to their personnel, and what we did was we correlated the ID number of the patient, or excuse me, of the provider. So whether it's a shield number or a license number or some identifier, and that translated to their roster. So if you were, medic number 1, 2, 3, 4, 5, all you have to do is enter that on the form. And then that correlates to what we've built up for you from this roster to be able to say this form submitted goes to you, put those two together. And then about a week or so later, we then synced back up with the management of the agency to make sure they understood what the data could do. They'd been aggregating this data passively, and it went up almost immediately. So within 24 hours, these forms were coming in. And now once the thing has calmed down a little bit, they understand the cadence, then we could sync up with the leadership of the department to essentially say, now here's how you look at the data to understand who's good, who's less good, who needs to be monitored, and so on and so forth. And one of the things that I think we found that was so intriguing, again, as a clinician, you'll appreciate this, because you mentioned about data coming in afterwards or the risk of that. Liability became a huge part of this conversation. It took about 10 days in Los Angeles before that started coming up, and a little less in some of these other smaller facilities. But we expect that after this crisis has passed, there's going to be a lot of second guessing. There's going to be a lot of lawsuits, right? And not just among provider agencies, but everybody, employers, and so on. And so the idea of having a paper trail to be able to say, here's why I told you you needed to go home, or here's why you might have wanted to go home, but you're not showing the symptoms to justify you having 14 days of paid time off. Because just because you spiked a fever doesn't mean you have COVID. It means you may need to go home and get well, but you may come back the next day and you had a one-day book. I think we're going to find a lot of this starting in the fall, right, when flu season kicks back up. So being able to tell the difference and really have that paper trail has been positioned by the agencies, that especially the early ones to adopt the system, as a way of helping to justify their decision making. And also be able to understand, as we evolve in phase 1 and phase 2, or wave 1 and wave 2, what did we learn about patterns of infection? That's been a very, very interesting part. We are in the process of submitting for some federal grants around the research and putting out some publications around those patterns that have been identified with statistically significant numbers of what suggested that you were, what symptoms could we identify in the field that would then correlate with positive or negative tests afterwards, and what does that mean for force readiness?
When the president's folks, Birx and Fauci, were trying to get a logical way for opening the country back up, one of the things they were talking about was tracking influenza-like illnesses, and trying to see when that changed, and who would know that better? Who would know that better than the frontline providers?
I'm so glad you say that. So I had a chance to speak with the COVID coordinator. He's one of the clinical directors for Los Angeles County Fire this past week. and I'm going to have that coming out soon. I'm happy to send you the link to the video soon. They're reviewing the edit right now, and um, the question that I asked, which goes to almost exactly what you just said, is would you and did you see your frontline personnel as essentially a proxy for the regions they were taking care of? Right? They are a canary in the coal mine. They are
Sure.
a human syndromic surveillance.
Yeah.
Because, if you're a station that's serving a neighborhood and you have coronavirus showing up in your personnel, either it came from your personnel or it came from the neighborhood, right? Because that's who you're being exposed to. Incidentally, in Los Angeles, and they gave very specific credit, they said they did not see that very much. And the reason is because they never ran out of PPE. So they were essentially protected from day one. They were very adherent. In fact, having seen the data, I can tell you that their personnel were almost on a hair trigger. If you sneezed within a 15-foot radius, they counted it as an exposure. It was very much like, let's make sure we're safe and so on. And so they were almost oversensitive. But the statement given back to me on that front was, yes, you're right. These guys are a barometer for their neighborhoods. The upside is if you take care of your people sufficiently, then they're shielded from it. And again, when we look at places, there's one of two scenarios that we see happening. One is what happened in New York, right, where you don't necessarily act as quickly as you would if you knew what was about to come. And so you do have exposures that might have been avoidable, or you lack the PPE to be able to shield yourself that effectively. The second, and this is what actually I get concerned about, is I have an academic fascination with false negatives. I tend to think that false positives get expensive, but false negatives are where things really go wrong, right? You think somebody was clear and they're not, and you let them out, and now you really have a problem when something comes up that's outside of your normal parameters.
Mm-hmm.
And so the idea that when you look at the Midwest, particularly, and rural areas of California and New Jersey, et cetera, as well, that don't have the same population churn as the cities do, they haven't had the patients show up. So at some point, they're going to stand down. And that's happening already, right? We know what this pattern is going to be. We see this train coming down the tracks. And yet we are seemingly powerless to avoid making the bad decisions. Because what we're doing is proving a negative, right? It is very hard to say the numbers didn't show up because we prepared so well. It is right. People are going to say, well, or we blew it, right? And so we overblew it, and so we killed the economy, and we stood up this overflow at this hospital when we didn't need it, and so now we're going to say, let's take it down. And if things show up at that point, you have a problem. Right? Because now you have to either spin it back up, or the way, you thought that was a little wave, and by the time you notice how big that wave is, you can't outrun it anymore. And so we're sort of caught in this catch-22. And I think that, again, is what the agencies that we have been working with are trying to avoid by saying, what if there's a middle ground? And that middle ground is watch, right? And have a monitoring system that doesn't stop you from doing your work. But again, contact tracing is kind of what it is. If I know that you are documenting your own health in a system that is easily correlated with your schedule, for example, and easily correlated with the testing results, then I have a single source of truth. And that single source of truth doesn't require me to lay multiple Excel spreadsheets down on a table and try to figure out what I'm looking at. It can be programmed. It's kind of a mini AI. For lack of a better term, right? And it sort of crunches all of these numbers and gives you a result that's actionable. And that's what we tried to do. But the most important parameter was you had to be fast. And so you ask a question, what do you need in order to stand up this thing? And the answer was a computer and a phone. Like, you don't need anything special. I have to get, because there's HIPAA, I have to give you some paperwork. But you can clear that paperwork in 15 minutes. It's not much more than a BAA and a software license. So that's great. Beyond that, you got to be able to spin this thing up right now, tell people to go to this link, fill in the form. As long as you can read, you can check, and you're done. And then everything else gets handled by the software. And isn't that what readiness technology is supposed to do? And
Absolutely.
so we squeezed this thing so tightly that it was faster to deploy than it was for me to explain to you on this podcast how to deploy it. How do you like that?
That's okay, but that's exactly what I wanted to accomplish in this time with you. You've blown my mind for actually understanding what our capability of seeing the earliest indicators, particularly in our providers, and doing two things: caring for our providers, making sure that they're appropriately cared for, and making sure that we don't have our EMS providers overwhelmed and the whole system collapse because we've been insensitive to their risk and haven't been managing their risk appropriately. But just as appropriately to actually take that and put it onto a community to be able to monitor that community's a very sensitive canary in the mine is a good way to do this. So this has been great. We're kind of at the end of our time here, but you've got my interest now for sure. And I think a lot of our listeners are going to say, okay, I want to know more about it. Tell us, so how can you find out more about Beyond Lucid?
So easiest thing, of course, beyondlucid.com. So that's Beyond Lucid. Okay. I have to make sure sometimes people what I mentioned at the front of this, I have small aspirations, like people knowing how to pronounce my name. Well, I want to make sure it's not Lucent. There is a Lucent Technologies out there as well. It's a big technology telecoms firm. That's not us. So this is about associated with lucid dreaming. Think of it that way. Beyond Lucid, so BeyondLucid.com. And right on the homepage, there's a link to the technology page for exposure tracking for COVID-19. The specific program that we use, it's called MetaView Trips. MetaView is our brand. Trips is our tracking program for non-acute monitoring. And so we specifically have an application of this for COVID-19. We have officially suspended all pricing. That's a question we get a lot, is how much is this going to cost? And I have put in writing, and I put in a video, and I'll put it again now on record too. The answer of how much it costs is how much you can afford. What you think it is worth, so to speak, to be able to take care of your own. Again, this is EMS week today. Happy EMS week, and to all who are listening, to EMS and fire and nurses and police and doctors, and we appreciate and love all of you. But we do not ever, with very, very rare exception, allow price to be the distinguishing factor of whether, or defining element of whether somebody can get this kind of technology. The way we look at it is this is folks taking care of our own, right? We have, if you're doing insurance-based programs, case management, if you're doing 911 transports, there are economic models for that sort of thing. But when it comes to taking care of yourself and ensuring that you can come to work tomorrow, what's it worth, right? Well, how do you even define that? So the idea of nobody budgeted for this, there was no plan. Right. So we came in and basically said, I have to charge more than zero because I have to house the data as HIPAA data for a long time, 7 years or so. Thankfully, when you're dealing with responders, you're not dealing with a whole lot of minors. So there's sort of a natural ceiling in there. But it is sensitive data, and we have to treat it as such, and we make sure people are trained and all that. But I can tell you, if I told you how little some people have paid for this software, you'd laugh. But that wasn't the point. The point was, it is an altruism, and I try to make sure we use that word. We've got a group of folks who've been coming together through social media and others recently to try to talk about unity in our industry. And there are certain events and certain topics that affect everybody, no matter your patch color, no matter your region. This is one of those. Right. And so it's an opportunity for us to come together, be united, recognize that we need to take care of each other. And if, as a technology company, I have the luxury of being able to, again, squeeze a technology that's rapidly deployable, its costs go down, it allows me to say, come as you are, large or small. I'm going to try to find a way to make sure that this is rapidly deployable without hurdles and without the need for extensive RFPs and all that sort of stuff, even if it's on a short-term basis.
Thank you, John.
They can also call me, by the way. 650-648-3727. It's 650-648-EPCR, and they can reach directly to us. And we're more than happy to engage. Again, we realize time is of the essence when you're talking about coronavirus. So
Right.
this is not the kind of thing that is a long burn.
To all our listeners, thank you for your time here, and we will post the contact points and phone numbers for John on the website. And we hope you've enjoyed this. It's been a speedy time to listen to a lot of information, but I think that's going to be very, very valuable. So
Thank you
to
very much
all
for
of our
having me.
listeners, thank you very much, and thanks for listening to EP Talk.